Hello everyone. I'm Dr. Ban Agha, a clinical senior lecturer at College of Dentistry, المستنصرية University. Today I'm going to present the role of craniofacial, skeletal, phenotype and ethnicity in obstructive sleep apnea, a systematic review and meta-analysis. I'm very pleased to be one of the presenters in the 6th annual scientific meeting of IAOR and the first Visual International Conference held in Baghdad. So my presentation outline will be background and aim, and then I will explain the methodology and result, and finally present the conclusion. I will be using the abbreviation OSA for obstructive sleep apnea throughout my presentation. To start with, OSA is characterized by repeated collapse of the upper airway during sleep for more than 5 abnormal respiratory events per hour. If you look to this circle, show the site of obstruction. So if the obstruction happen more than 5 events per hour, we call this condition obstructive sleep apnea. The estimated prevalence of middle-aged population is 9 to 24%, with men to women ratio 2 to 1, and this means it affects men more than women. However, the prevalence rates have significantly increased over the last 2 decades, with increasing age and obesity. So the risk factors is increasing age and obesity to develop this obstructive sleep apnea. So OSA remains underdiagnosed and undertreated sleep disorder with very significant negative health impact on both the individual and the community. These can include daytime sleepiness, increased cardiovascular morbidity and mortality, motor vehicle accident, and cognitive convulsion and decreased quality of life. And they are a risk to us all. From the available evidence in the literature, OSA is a complex, multifactorial condition resulting from a combination of anatomical and contributing factors. A recent meta-analysis of cephalometric studies has found a strong correlation between OSA and a limited number of skeletal parameters, which include increased lower facial height, decreased pharyngeal airway area, and lower height position. And if we look to this diagram, so the lower position of height, the letter H here with the mandibular plane, and also increase the lower facial height, the distance from an ANS to the menton, and decrease in pharyngeal airway area, and this area behind the tongue decrease in this area. However, the available evidence is insufficient to confirm the existence of craniofacial phenotype in adults with OSA. So we cannot rely only on these features. That's why we need to look to other studies. However, due to the number of study limitations, why these we cannot rely and to say there is a specific phenotype for OSA, skeletal phenotype, because there is a limitation in these studies, like ill-defined sample, great variability in measurements method, with little or to no recognition of head position during image acquisition, and a failure to confirm the absence of OSA in controls. So some studies, they did a sleep study to confirm, to see if they have more than 5 events per hour to confirm the existence of OSA. And also they did for controls the sleep study to confirm the absence of these events in this control group. So we have a very well-defined sample But most of the studies, they rely on questionnaire to identify they don't have this condition. For example, they ask them, do you snore? Do you have any feeling of choking or during sleep? Or they ask the partner if you heard or you are eyewitness of stop breathing for more than 5 times per hour. So only they rely on questionnaire, and this they are not good in for study design. So if we have objective measurement like sleep studies, so they put a machine and they measure the heart rate, the pulse rate, and also they measure the flow rate, the respiratory flow rate, and to see if there is any obstructions or not. And to date, attempts to report an ethnic contribution to etiology of sleep apnea have been significantly limited to investigators comparing mean values of one ethnic group to those of another. More recently, the importance of an OSA phenotype has become the subject of discussion. So when we talk about phenotypes, it's that mean the morphological characteristic features of genotype. So if we have genes to have this specific morphology, so the phenotype present that it look like a morphological characteristic of genotype. So let's say the OSA phenotype divided into anatomical and non-anatomical. So anatomical, we can look to the surface, so the surface morphology, let's say the face, or the skeletal, and looking to the measurement of skeleton and the measurements of the airway. While non-anatomical or non-morphological characteristic could be excessive daytime sleepiness as a risk factor, low respiratory arousal threshold, high loop gain, impaired upper airway dilator muscle. So the OSA phenotype broadly divided in anatomical and non-anatomical, as I said. So in view of time constraint, I will primarily focus on anatomical feature. So the phenotype, from the phenotype, we can predict the OSA patients. So just looking to their face or their posture or their X-ray, we can predict the OSA condition. So I publish a research talking about the facial phenotype, the surface phenotype, the shape of the face from soft tissue features. And we identify only 8 studies in the literature. It's a systematic review research. And from these 8 case control study comparing OSA patient with the controls, we couldn't find a defined phenotype because the study was ill-defined and there is just limited characteristic. We found like a large neck, and also we found increased lower facial height, increased total facial height, and increase the width of the lower area, let's say the lower face, the width. And all these measurements is related to obesity. We can say there is like a camouflage of obesity. We cannot identify the exact risk factor or the etiological factor for OSA from just looking to the surface. So the aim of this study to explain the existence of craniofacial skeletal phenotype in adults of different ethnicity with obstructive sleep apnea, and also to identify the role of ethnicity in OSA. So we're not only comparing, we want to see if there is a difference when we compare like specific ethnic group with their controls, and then also another ethnic group with their controls, and we do a specific statistical analysis. We call it two-way interaction analysis, and to see if we compare two populations in regards to their controls, is there any difference? Does ethnicity has a role in obstructive sleep apnea or not? So the study protocol was registered with International Register of Systematic Review, and comprehensive search was conducted by exploring a range of electronic databases, and no restriction on language or year of publication was applied. And if we look to the study selection, the PCOS principle, we can see the patients, they are adult, they have no anomalies, and they have a confirmed diagnosis of obstructive sleep apnea, having 5 abnormal respiratory events per hour, more than 5 events per hour, and regardless of their weight, if they are normal or obese, and any craniofacial syndrome, as I mentioned, excluded. All the study have used lateral cephalogram, and we exclude any cone-beam CT because the rendering 3D to 2D may cause error or let's say a magnification error that may make artifacts in the measurements. And we compare the patients, the OSA patient with control group, and we extract any linear, angular, or area craniofacial skeletal measurements of Caucasian, Asian, or any ethnic groups. The study limited to observational study, only like case control, cohort study, cross-sectional study, and any study with participant less than 5 were excluded, as it's considered as a case study. And if we look to the study strategy here, we use the Prisma flow chart to show how many search or papers we identify about 2011, and after we remove the duplicated, it become 1,432. And at the end we look to the eligibility, and it reached to 140. And we also exclude all these articles because of there is no confirmed diagnosis of OSA, or there is no controls, or they use CBCT. If there is any limitation from the if there is any thing that may cause a bias, also excluded, like retrospective studies. So we only use prospective studies in this research. So finally we reached to the 85, and only 36 studies included in meta-analysis, including 19 Asian, 15 Caucasian, and 2 Indian papers. And we exclude 22 because some of them have duplicated research. They use the duplicated controls, or they use specific malocclusion, like class 2 malocclusion controls, or the data not presented as a mean. We cannot change the setting at that time, or the low quality of study also excluded after we identify about 16 study that would have low quality. So finally we only include 36 in the meta-analysis. And how we did this? So we looked to the risk of bias assessment, how we identify 36 out of 58. We use a Newcastle Ottawa quality assessment scale to identify. It's look like to identify the weak or the good, the strong study. It's look like a tick boxes to see, and we look to these main 8 questions, 4 questions regarding the selection of the participant, and 1 regarding comparability, if they are comparable with the controls or not, and 3 for the outcome questions. And there is a high inter-examiner agreement was observed about the IRR 0.9, and all 36 of include study just to be high to moderate quality. And if we look to the pooled result, we mainly find, as I mentioned, Caucasian and Asian, and only 2 studies for Indian, so I focus only on these ethnic groups. So I compared the Caucasian and Asian regards each linear measurements or angular measurements. So this angular measurement, cranial base angle, we can see the BASN. You can see here for the first meta-analysis, all the studies on the left side, in the side of OSA, and in the minus, that means there is a reduction in this angle. And also you can see in the Asian as well the same pattern. So both of them, regardless they are, when we compare them to the controls, regardless whether they are any ethnic group, they have the same pattern. That mean the OSA have smaller BASN angle. And if you remember when I talked earlier, when we compare directly Caucasian with Asian without looking to their control, the Asian will have maybe smaller or the Caucasian have larger without knowing their consideration according to their control. So the OSA impact we cannot identify without comparing to the control. And also we compared with, we did pull this result according cranial base length as well, and you can see the same pattern, both of them, the Caucasian and Asian, reduction in this length in both population. And again, we pulled the result according to the bony nasopharynx, the length between the basin and to the posterior nasal spine, and they have also the same pattern reduction in these measurements. When we look to mandibular prognathism SMB, which is the characteristic feature, it's the retrognathism of the mandible for the OSA patients, we can see in the Caucasian and Asian there is variation in this measurement. Some of them they have a decrease in these measurements, others they have no difference between controls and OSA, and others they have increase in this measurement. But if we look to this small diamond, it's the position is behind the 0, it's in the minus. So in both groups, Caucasian and Asian, and this shows that there is a reduction, the total effect reduction in this measurement, the SNB measurement, the overall effect. It's about 1 degree, 1.2, and in the Caucasian and in Asian 1 degree reduction than the controls. And this show this in this meta-analysis there is a big heterogeneity between studies, but the total effects show there is a reduction in this measurement. We can see the same pattern reduction in the mandibular length from gonian to menton, and this measurement is also a characteristic feature for sleep apnea patients when compared to controls. And in this meta-analysis, both group, Caucasian and Asian, have the same characteristic feature of reduction of mandible length. And you can see the diamond here, its position in the minus. It's about reduction in 4 millimeters in the Caucasian and 3.5 millimeters in Asian. And also the main impact of obstructive sleep apnea is the lower position of hyoid. So you can see there is increase here. The OSA group have increase in this distance comparing to the controls in both population. So we can see all these measurements, and there is we run a lot of meta-analysis, but I just pick up the highlighted, very well identified measurements. It's published in the literature a lot and talk about the decrease in the mandible length, the retroposition of the mandible, and also lower position of the hyoid. So all these and also decrease in the cranial base, angle and length. All these have a characteristic feature in both Asian and Caucasian. And then what I did, I need to know if the effect of ethnicity, because they have a specific ethnic group, they have reduction or not, because some study they didn't look to controls. They directly took the OSA patients and OSA patient in Caucasian comparing to OSA patient in Asian, and directly compare, and they said OSA, they decided and given conclusion that the OSA Asian have more craniofacial abnormalities than Caucasian. But in reality, when we compare normal Caucasian population to the normal Asian population, they have the same comparison, because each ethnic group has its characteristic feature. So when I look to the OSA, if we look to this table, it's more sophisticated analysis. It's about talking about the module include the main effect for ethnicity and OSA here, and we subtract Asian from Caucasian, and then OSA from control, and finally we found here, if we look to the P value at the end here, most of them, they are non-significant. And because of a lot of the subject here is too high, so we run a correction, and we only could take this angle, the Gonian angle, articular Gonian menton angle, considered as an effect in ethnicity. They are smaller in Caucasian than in Asian, and from this we can conclude there is no rule of ethnicity except this angle. And because this angle, the orthodontist, they knew about this angle, it's very difficult to identify this angle, and maybe because of the error in the measurement that give this interaction of significant. You can see here there is also 3 significant parameters here, but these considered as not significant when we run Bonferroni correction, because if we have a large number of study or participant, we need to run the Bonferroni correction to identify the significant by dividing the total number of participants over the measurement. To sum up, there is a skeletal craniofacial difference between OSA subjects and healthy subjects, with promising evidence of the presence of skeletal craniofacial phenotypes. Not like our findings in the surface systematic review, we couldn't find a clear phenotype, and in this systematic review we found some evidence, because as I mentioned before, some studies has a ill-defined sample, and we cannot rely to say we have a specific phenotype, but we found some evidence that showing there is a specific phenotype in each ethnic group, and they have the same pattern in terms of shape of the mandible, or the position of the hyoid, the lower facial height, and other measurements. And based on two-way interaction between OSA and ethnicity in regards to skeletal craniofacial variables, we found there is an evidence to suggest there is no influence of ethnicity in OSA skeletal morphology. So, suggesting OSA subjects have common features when compared to their norm population. Therefore, craniofacial comparison and prediction model should be tailored for each population separately. When I present the table of two-way interaction, we found only the Gonian angle show there is ethnic difference between the group in regards to their norm population. However, all the other measurements show they have the same pattern. All of them, they have the same effect on the skeleton. So this explains there is no rule of ethnicity except for the Gonian angle. In conclusion, skeletal craniofacial morphology was able to demonstrate some characteristic morphological feature in adults with obstructive sleep apnea. However, the skeletal craniofacial risk factors show no potential ethnic influence. Thank you very much for your attendance and listening to my lecture. If you need any further questions, you can email me on this email, and welcome any question. Thank you.